Anything with oncologist Dr. Linda Vahdat. And we're so excited to have her here with us. So thank you very much for joining us this evening. My name is Nancy Toohill. I'm your peer facilitator for this group, and very excited to be handling this conversation tonight. We've had a lot of great questions come in, but feel free to, which I'll run through, but feel free to submit additional questions in the chat. Due to time constraints, we might not be able to cover all of them, but we will certainly try to cover as many questions as possible. And we do ask that you keep your questions to a general nature. Dr. Vahdat cannot offer specific medical advice through this forum, so please keep your questions on the more general nature. The program is being recorded, and it'll be posted on a share website in 1 to 2 weeks. So please feel free to look out for that if you'd like to listen again. And now it is my pleasure to introduce Dr. Vahdat. She is the Chief of Cancer Services and Head of the Department of Hematology Oncology at Memorial Sloan Kettering Cancer Center, Norwalk Hospital Partnership. She's a member of the Breast Medical Service at MSK and Professor of Medicine at the Weill Cornell Medicine in New York City. Dr. Vahdat earned her undergraduate degree from Barnard College, Columbia University in New York City, and completed her medical degree from Mount Sinai School of Medicine. Although a translational breast cancer medical oncologist by training, Dr. Vahdat's expertise is in drug development and has been involved in the identification, conceptualization, design, and conduct of clinical trials of new therapies in high-risk adjuvant and metastatic breast cancer patients since 1994. She has led 4 separate drug development efforts that led to FDA approval in 3 drugs active in metastatic breast cancer. She founded the Triple Negative Breast Cancer Clinic, the second in the US, in 2014. So thank you so much for being here, Dr. Vahdat. I'm going to start us off and just ask you what led you to the field of oncology?
I've always been interested in oncology, and it wasn't even, it wasn't because there was anybody in my family who had cancer, is something, because that tends to motivate a lot of people. I just felt that there were so many unanswered questions in the field that there would be a lot of work to do. And it's really funny because I was very involved in the New York City science fairs. I grew up in Brooklyn, and it was interesting because, when I look back on what my project was, it was some high school student, right? Little Girls Catholic High School in Staten Island, was looking at the effect of radiation on, how it affects blood vessels. So even like back then, I was sort of segueing my way into things that are cancer related. And actually, I really like cancer patients. I find them to be very proactive. I find that they really want to help themselves. So I felt like it was just a good fit.
Excellent. All right, I'm going to dive right into the questions. I have muted everybody on the call just so that there's not a ton of background noise. So feel free, like I said, to ask any additional questions in the chat box, and I will ask them of Dr. Vahdat. Okay, so starting off, can our immune system recognize cancer cells and sometimes destroy them? I saw an online video with voiceover on immune system cells, and it showed one type of cell destroying an isolated cancer cell as part of its normal immune function. However, I recently attended an NYU-sponsored breast cancer event, and the oncologist said that the immune system cannot recognize cancer cells. Which is it, or is it more nuanced than that?
Well, I'm just going to say that I'm not, an immunologist by training. However, I do feel pretty confident in saying that our immune system does recognize cancer cells and can fight cancer cells. If you think about it, cells are dividing all the time. And as they divide, they exchange, if you go back to basic biology, you have one cell, it replicates its DNA and then it has to split into 2 cells. And sometimes that doesn't always happen perfectly. So if there's a problem with that, and the DNA is somehow messed up, right? So think about it as a spell check, like you have in your Word documents. you have processes which include immune cells to sort of cart those cells off and destroy them. And part of what carts itself off and destroys it are immune cells. So I would be in the camp that says, yes, immune cells can fight cancer cells without any intervention.
Okay, great. Why would the American Institute for Cancer Research say that a Mediterranean diet could keep cancer from recurring if our immune system is incapable of recognizing cancer cells? In other words, by what mechanism might lifestyle influence cancer prevention once you've already had treatment for cancer and have no evidence of disease?
We've already established that your immune system can recognize cancer and take care of it. But there's always been a lot of interest in diet on outcome. And there have been many studies that have been sponsored by very large governmental organizations to really look at the effect of different types of diet on recurrence in breast cancer. First of all, incidence of breast cancer and recurrence of breast cancer. And so you may have heard things like the Physicians' Health Study, the Nurses' Health Study. These are very large epidemiologic studies to which they pose questions in which they have, decades of data in order to try to answer those questions. So there's always been a lot of interest in diet, and the Mediterranean diet, which is very heavy, on vegetables, grains, low in red meats, a little bit of red wine, lots of olive oil, has always thought to be a very well-balanced diet. And they've done a lot of studies looking to see if that can reduce recurrence risks for various types of cancer. And there was actually recently what we call a meta-analysis, which is basically where they take lots of different studies, they pool all the information and see if, by pooling the information, you have like more information, can they make a statement, which may not be seen in some of the smaller studies. And so because I knew about this question, I actually did a literature, as Nancy knows, I did a literature search, because I'm not a diet expert either. And basically there was a large meta-analysis that really demonstrated that a Mediterranean diet can reduce recurrence risk across a host of cancers. And so when you reduce recurrence risk, you also improve mortality, you decrease mortality and overall well-being. So, again, a well-balanced diet, which happens to be a Mediterranean diet, is very good. And probably one of the things that it really sort of factors in with is that, when you have a well-balanced diet, it's less likely that you're going to have a high body mass index, right? You're not going to be so fat, right? And one of the things that there's really, over the past 10 years, there's really been been developing a very strong link in terms of obesity or high body mass index and risk of recurrence. And part of it is that what they find is that these adipocytes or fat cells, what they do is that they basically facilitate metastasis by making it easier for cancer cells to travel. So if you sort of think about it, that, the more fat you have, you think about it as a paved road, like a highway that cancer cells take to get to the next site. Whereas if you're slim and, have a low body mass index, low, what's low? Or I should say normal, less than 25, is that it's not a highway pavement, but it's a gravelly dirt road with maybe pieces missing out of it. So it really is not easy for cells to travel. So, how much they're all related, I don't know, in terms of Mediterranean diet and body mass index and obesity, but it appears that, I wouldn't be surprised if there's some strong connection there.
Interesting. Okay.
Like everything, thin is better. Everything. If there's anything where thin isn't better.
All right. There is a blood test, Signatera, that I believe can do circulating tumor DNA monitoring. Is this accurate? Why isn't it in clinical use? And in one experiment, 18 women out of 230 were identified with tumor markers in their blood. 16 went on to develop metastases and the other 2 did not. Why might these 2 women have not developed metastases, or could the test results have been inaccurate? It's a multifaceted question there for you.
Talk about ctDNA. So ctDNA or circulating tumor DNA is a super exciting research area these days. And I say it's research specifically because what we're trying to do is understand what do we do with that information. So if we have that information, we make an intervention, can we affect outcome? And it sort of all goes back to you don't want to overtreat people and you don't want to undertreat people. So we're hoping that something like a ctDNA can help us. And what ctDNA is that basically tumors can shed little bits and pieces of themselves in the circulation that you can pick up. And so there are a number of different assays out there. There's Foundation Liquid, there's Garden 360, there's Signatera. And so all of these, I think Tempus has one. So there's lots of these assays which are being utilized in people who have a lump of cancer that you can see, and people who maybe underwent therapy and they have no cancer that they can see. So so it's really useful. And sometimes you'll hear this referred to as a liquid biopsy. And one of the ways that it can be utilized is that if there's something you're looking to biopsy, a lump of cancer that you can see, but maybe it's not so easy to get a piece of it. Sometimes you can draw this blood test and you can do this ctDNA. Now, I think what our question specifically is referring to is sometimes people get treatment up front, chemotherapy, we call it neoadjuvant chemotherapy to shrink tumors down. And then the best thing we have in order to figure out how someone will do is when women who have neoadjuvant therapy, they get surgery and they have some disease left behind when they have a lumpectomy or mastectomy. That's the only thing that we have to I would say in the past to say, well, number one, does someone need extra treatment, because you can put some numbers on their risk of recurrence. And so some of the work that's been done with ctDNA in people just like that show that if you have residual ctDNA, meaning bits and pieces of tumor still floating around in the system that you can't see or measure, then what we've seen is that those patients have a higher risk of tumor coming back. And where everybody's going with that is that, well, gee, if someone has some residual, some ctDNA, should they get some extra treatment? Because right now, at least for certain kinds of breast cancer, if there's any residual disease in the breast that we get rid of, right? So technically patients have no evidence of disease, they'll still get some additional chemotherapy. So there's a way we can, we can maybe stop overtreating people. Now, ctDNA is a little bit tricky, and it's a little bit tricky because there are different ways to measure it. And so Signatera, what it does is that it actually gets a piece of the tumor and it sequences it. And they call that whole exome sequencing. And so what they look to do is look to see what the specific mutations are. And then what they do is they create a panel in order to investigate it moving forward. So like, for example, if you have a particular mutation, let's say a TP53 mutation, which is very common, they'll make sure that the panel that they're looking at has a TP53 mutation. So not to like muddy up the waters a bit, but this is especially important because there's something called clonal hematopoiesis, and sometimes some of the things that might be construed as tumor DNA are not tumor DNA in the blood, and that can muddy things up. So I would say that ctDNA is among some of the most exciting things that's happening in terms of diagnostics. What we don't know yet is if you see someone who has high ctDNA and you intervene, that it makes a problem, that it makes a difference. Because I would say sort of the precursor to this, not as good, was something called circulating tumor cells. And they actually did a study where they tried to use circulating tumor cells to basically change therapy, to help us decide when to change therapy, and it didn't make a difference. So it's emerging. And how do all those assays compare? I'm not really 100% sure. The thing is with those assays, they call it, I'm going to do another acronym, MRD, minimal residual disease, MRD assay. So the issue is how low can you go? Like what is this threshold for detection? So I really think over the next few years, the technology is really going to get a lot better than what we have, even other than the Signatera assay. And everyone's really working hard on it. I've seen a lot of publications in that realm. So super exciting. Stay posted.
Thank you. All right, I'm going to ask a question from the chat. I had my second treatment with Taxol and now have some neuropathy in my fingers on my right hand. Would icing help at this point, or what can alleviate this without resorting to neurotinin at this time?
Yeah, so definitely icing of your hands and your feet can make an enormous difference. And you should go to Amazon and buy the booty, the booties and the mittens. If you're wherever you're getting treated doesn't have those, but it actually makes a very big difference. It's sort of the same thing as when people get adriamycin, if they get, people used to get mouth sores, we give people ice now. So they suck on ice and they don't get mouth sores. Same thing, we put a cold cap on their head and they don't lose their hair, for certain kinds of chemo. It's the same thing with the hands and the feet. So that would certainly be my first approach to try to prevent peripheral neuropathy.
Great, thank you. Can you talk about TNBC vaccines? How do they work and when will they be available?
So the vaccines, there's a lot of activity in the vaccine space right now. And so basically the whole idea behind a vaccine is to immunize you against something, right? In this case, triple negative breast cancer. And the thing is, when we talk about making a vaccine like to COVID-19, right? You have a very specific target. So they've made targets against those spike. I'm sure everyone's heard about this in the news, against those spike proteins on COVID-19. So triple negative breast cancer doesn't have spike proteins, and triple negative breast cancer, as well as most breast, they all have very different characteristics. So that's why it's been a little bit challenging to make vaccines against triple negative breast cancer specifically. And when sort of the technical term for that is, there's a lot of what we call tumor heterogeneity. So what you're always looking for is what is the most common characteristic of triple negative, so that you can maybe target the majority of tumors. And so there've been a number of vaccines. There are a number of them that are in trials. And, this was a question that came through before, so I did a quick lit search just to see where most of them were. And I don't want to say surprisingly, but it actually is a very robust portfolio at WashU in St. Louis, Missouri, with, some good pilot data. But they all target different characteristics of the triple negative breast cancer. One of the things that I saw that they were targeting is a protein called mammoglobin. And I think that trial is open, but it hasn't started accruing yet. There's another trial that's been open, I know, for several years, looking at the folate receptor in breast cancer. And that is, I think it just finished its accrual according to nci.gov. And so, the goal would be there are a couple of different goals, but I think the biggest goal is that when someone has been diagnosed with a triple negative breast cancer and they're sort of at the tail end of their therapy, that you would give them a vaccine to help to prevent recurrence. So, I'd say some of the vaccines that are the furthest along are not in triple negative breast cancer. They're probably in HER2 positive breast cancer, because HER2 positivity is a very distinct target with lots of different treatments. So that's where I've seen most of the movement.
Got it. Do you know of any that are in stage 2 trials? And do you know how the vaccines are tested? Are they tested in humans or on removed samples?
So the ones that I've looked at, there are various what they call eligibility criteria, and some of them are looking for particular characteristics. So they'll take an archived tumor sample, from before, and they may test it for a couple of things. Usually they'll test it for the presence of or absence of particular antigens or characteristics. And sometimes what they do is they actually test people to see if they have particular immune profile. So we call it HLA typing. So some of the vaccines they find that they only work in people who have HLA A2 or something like that. So I think it really varies by trial.
Yeah.
But a good way to research it, the way as I always research it, is I go to clinicaltrials.gov. I type in triple negative breast cancer, and then you type in vaccines, and you get a whole. I think I got a listing today of 29 vaccine trials, which are sort of either recently completed open, not accruing, or recruiting.
Great.
So that's, you can be proactive and sort of keep on top.
Awesome. Thank you. All right. Some scientific experiments have shown that removing the amino acid asparagine helps reduce metastasis. Do you recommend a diet low in asparagine-rich foods to prevent TNBC from recurring? Complete removal of asparagine from a diet would be very restrictive. Is there some sensible way to lower this amino acid in the diet?
So I guess I'll tackle the easiest part of this question first, which is I would not recommend removing asparaginine from your diet, because asparaginine is important for lots of cellular function, including immune function. And sort of what this question sort of hits at is the fact that there are lots of different approaches to change what we call the metabolic microenvironment that promotes metastasis. And there's been a lot of work done, I would say maybe over the past 4 or 5 years, really looking at how to change, the microenvironment to make it hostile to tumors spreading, because things have to be sort of perfect for tumors to spread. And so if you disrupt all the food that it needs, then, maybe these cells will just shrivel up and go away. And so whether it's asparagine or tyrosine or pyruvate, these are all important amino acids just for normal cell function. So I would say, at least for now, there's no real practical way to affect that, although there are trials looking at all of these different approaches.
Okay, great. When is triple negative breast cancer most likely to recur? And are triple negative patients usually followed closely during this time period? And how are they followed?
Yeah, so if you were to look at lots of, we call it population-based data on what is the time course of, to what happens in people with breast cancer, specifically triple negative breast cancer. One of the things that we see is that with triple negative breast cancer is that the greatest peak of recurrence is 3 years. Now that's very different from someone who has a hormone receptor positive breast cancer, where usually the peak recurrence is, somewhere between years 5 and 10. So for triple negative, it's 3 years. Usually if someone makes it to 5 years without a recurrence, they're just about good to go. And then if they make it to 7 years, then it's super unlikely that anything will ever happen. But really 5 years is an important number for triple negative breast cancer. And in terms of the usual follow-up, I would say probably most oncologists follow American Society of Clinical Oncology guidelines, which is usually what we do is that there's a visit with your medical oncology team once every 6 months usually. At that time, what we do is that we talk to our patients, we examine our patients, and then if there's something which needs to be investigated further, then we'll order more stuff. So we might order bloods, we might order imaging, but I would say that it's not like everybody who walks in the door is going to get a blood test or get a CAT scan once a year, and part of that is, that's how we used to do things. I'm going to say 15 years ago, at least more than 10 years ago. As you can tell, I've been an oncologist for a long time. And where everyone used to come and see us, every 4 months. We used to do all these bloods, including tumor markers, and we used to, at a minimum, do a chest X-ray once a year. And so there were a series of clinical trials that showed that you weren't really catching things any sooner. And people weren't living longer because of that. Really, all they were getting was, more radiation from the chest X-rays or the CAT scans. And so, we're really trying to be a little bit more, smart about it. And you can talk to people, right? There are certain things oncologists are always looking for, and you examine people. Good old physical exam as the jumping off point.
Interesting. Probably reduces some of the anxiety surrounding scans as well, I would imagine.
Yeah, it's interesting because it's almost like damned if you do, damned if you don't sometimes, you know what I mean? Because on one hand, I found that some patients want to scan because then it'll give them confidence, but on the other hand, they don't want to scan. And I feel like oncologists feel that way too, And yeah. I think we have to be careful about the radiation. We've been really scaling back a lot on the radiation piece. from radiology studies.
Yeah, interesting. All right, I'm going to ask a question from the chat. What is the longest period of time you have seen individuals using capecitabine? Did I butcher that?
Yeah. So the longest I've ever had a patient on capecitabine is about 5.5 years before we needed to switch to something else, and using capecitabine in the metastatic setting.
Thank you. Can hemp products be harmful in any way for cancer survivors? In other words, can they encourage cancer to grow?
So when you say hemp, I think of things like cannabis. So that's the sort of the angle I'm going to come from. I don't know if there's some shades of gray in there. And so I haven't seen any negative effects. The only thing is that, because again, I'm thinking about it through, cannabis, they're all sort of related, is that it probably shouldn't be combined with tamoxifen. And I think that's a warning actually from FDA also.
Interesting. Okay. Most doctors recommend a healthy diet over supplements, but are there any supplements that you can recommend to prevent recurrence?
I'm not aware of any supplements that can prevent recurrence. I would say that, most patients are deficient in vitamin D. So, so that's a supplement that I have a lot of my patients take. Their primary care doctors, usually monitor that, but this is something that I observe. The other thing is, calcium. And, my understanding of calcium is it always goes back and forth with cardiovascular disease. So again, I sort of let the internists who are more up to date on that sort of take control of that. But those are the two sort of supplements I always see people take. I mean, sometimes I see people take omega-3 fatty acids, turmeric, all those kinds of things. I would say the omega-3 fatty acids can help with some of the aromatase inhibitor associated joint and muscle aches. We use that for that. So that's really it on the supplements for me. And the other thing I do while I'm thinking about it is that because there's so much information out there, and no one can be an expert in everything, is that I send them actually to the integrative medicine services at MSK because they are really good. And also the integrative medicine service has a great website. And I've heard so much great feedback from patients about, free website, just go to it and you can do a lot of research on supplements if you're interested.
Awesome. Okay, thank you. Are there any new oral medications used to treat TNBC?
So I would say that there are lots of new oral medications. I would say they're not necessarily approved for TNBC, or they're not applicable to patients with TNBC. So, when I think about, some of the drugs we use that are oral, that are maybe not standard, usually they're genomically driven. So genomically driven, meaning that a tumor was sequenced, had genomic sequencing, and there was a target there, and they went on a trial to get a drug, an oral drug, and the oral drug helped them. It helped them in that it shrunk the tumor down, kept it shrunk for a while. So things that are genomically driven, or you could say are some of the new ones, but they're not specifically for TNBC.
Okay, thank you. Before we move on, can you remind us one more time the name of the integrative medical site that you were talking about?
Sure, it's at Memorial Sloan Kettering. If you put integrative medicine, Memorial Sloan Kettering, it'll pop up.
Thank you.
I've gotten so much good feedback. I really should go and look at it more, but patients really, the feedback I've gotten has been very positive.
Okay, awesome. Thank you. So I'm going to go ask another question from the chat. What do you know about having triple negative breast cancer and the PALB gene?
So PALB2 is a breast cancer gene. It is associated with triple negative breast cancer as well as other breast cancers. There is an association with ovarian cancer with PALB2. And I guess the good thing is that PARP inhibitors also work in tumors that have PALB2, which is important. So it's just, it's emerging. I mean, there was a paper, I'm going to say maybe about 1 or 2 years, and I'm going to say it might have been from Canada, where they really was a great overview of PALB2 and outcome and relative risk for different other kinds of cancers. So it's really it's really we know a lot more about it now than we did 3 years ago.
Yeah. Okay, great. Interesting. We talked about vitamin D already, so I'm going to ask another question. Can triple negative breast cancer return years later in the same breast or the other breast? Would that be a primary recurrence, or would it just be considered a secondary cancer?
Well, it depends. So you certainly can have in-breast recurrences, at a site of prior treatment, or you can have a brand new unrelated primary in a treated breast. Sometimes it's easy to figure out, and other times it's not. So, ways to try to help figure it out are that you have the pathologists look at the old slides from the prior breast, and they look and say, well, first of all, do they look about the same or not? Sometimes if it's a new primary, we looked for something called ductal carcinoma in situ, and if we see that, then we're pretty much hands down, it's a new primary. If something happens in the other breast, that more often than not, it is a new primary, because it's really not that common to have a metastasis from one breast to the other breast. It's pretty rare, actually. And of course, ultimately, we don't really do this so much now, or maybe in the future we will, but I think with the price of sequencing and the availability. So like, for example, you'd have to be at a really good place for this, where you might, if you're not really sure, and if it really made a difference in terms of treatments, you can always do sequencing of the individual tumors. So that's next generation sequencing of the tumors. You could see if they're similar or not. And sometimes you get surprised,
Yeah.
do all that sequencing, but I don't even know how much it costs, but I think it's pretty expensive. I'm going to say it must be somewhere between $3,000 and $6,000 for sequencing, I'm guessing. And then you need to have really good people do it. One of the things about MSK, MSK is not a perfect, I shouldn't say that's not a perfect place, but one of the things they do really well, because it's recorded, but one of the things they really do amazingly well is the genomic sequencing. It is incredibly impressive. So, and for us, when we do it there's most of the time there's no cost. So that's even better. You can explore. Yeah.
Wow. Okay. So this question says, I have a history of breast cancer in one breast, and now the other breast is leaking fluid. What does this fluid mean?
Good question. You need to go see your doctor. Let them do imaging, and it's probably fine, but it needs to be checked out.
Yeah. All right. Can women with metastatic triple negative breast cancer go into remission?
Yes.
Excellent.
I mean, there are lots of different ways to go into remission. So yes, it absolutely happens.
Good. Okay, I'm going to ask a question from the chat. Is it common to have triple negative and ER/PR positive breast cancer in the same breast? If so, can there be a recurrence of both for a patient with no history of cancer in their family and negative for BRCA?
Yes. So what that is, you remember breast cancer is like a bunch of grapes, and all the grapes have different kinds of, different characteristics. So having two different primaries in a breast at the same time, I mean, we do see it. And so usually what drives treatment is the more aggressive one. But we do see it. So I have a lady who she's in her, I say maybe she's just about 60, who basically had a hormone receptor positive breast cancer, and then had a very, which was, maybe about 1.5 centimeters, and then she had a triple negative breast cancer that was like 6 millimeters. So, that tiny little triple negative breast cancer is what drove her treatment to get her adjuvant therapy. So she got her adjuvant chemo, And then we put her on a hormone afterwards to sort of deal with her low oncotype hormone receptor positive breast cancer.
Makes sense. Yep.
Yeah.
Okay. Ivermectin. I recently read an article about using ivermectin to turn TNBC tumors from cold to hot. In animal studies, it seemed to have good results. Can you comment about whether or not you think this is a promising treatment in humans in the future?
So I think it's very interesting. And again, it goes back to changing the tumor microenvironment. So specifically what the ivermectin does is it really increases the infiltration of T cells into a tumor, immune cells to fight cancer. And so you're changing the environment to allow them to do that. So this is a classic example of drug repurposing, because ivermectin is used for parasites. So I didn't look to see if there was a trial ongoing and clinicaltrials.gov, but I wouldn't be surprised if there is, to really study this in a more formal fashion. It would be very easy to do. And it would be really very valuable for patients if you could take a relatively well-tolerated drug and change how your immune cells function in a positive way.
That sounds really interesting.
Yeah, it does.
Yeah. All right. Are there any medications that are given after treatments have ended to stop triple negative breast cancer reoccurrence?
So right now there's, people are looking at some vaccines, but those are limited. One thing that I usually give my postmenopausal patients, they always give them a bone strengthening drug. And you might say, bone strengthening drug, why would you bother doing that? Well, it goes back to altering the tumor microenvironment. And there's a whole body of data that suggests that if you do take a bone strengthening drug like a Fosamax or a Zometa, that you can further reduce risk of recurrence by about 2.4%. And you might say, oh, 2.4%, not a big number, but you know what, it's significant. And most of the people I talk to figure, it does double duty. It helps to keep your bones strong and helps to prevent recurrence. And there are two ways, that you can get that family of drugs. They call them bisphosphonates, either an IV once every 6 months, and usually for about 3 years, or a pill. And the side effects are different because that family of drugs, sometimes the IV form can be associated with a problem with the jaw, which is rare but real. So I always tell my patients I'm going low tech and just give them Fosamax once a week and for 3 years. So that's really the adjuvant therapy that I use, at least for now. And we've been doing a lot of work on metals in cancer, specifically copper depletion. So we are hoping to launch a trial probably by the end of this year, looking at copper depletion pills that they use for a disease called Wilson's disease, in order to help to prevent recurrence. And again, by affecting the tumor microenvironment, we're hoping to prevent metastasis.
Excellent. Okay. I have done Taxol and Doxil, and now I'm on Trodelvy. What is available after this?
So there are lots of other drugs. So there's obviously capecitabine, Exempra, Navalbine, gemcitabine, Carbo. We would also look into clinical trials. There are a couple of interesting clinical trials out there right now. Most of them, again, are, at MSK, most things are genomically driven. But there's a couple of really interesting things. They have an ATR inhibitor. There's just a lot of stuff. So it's important for you to do your homework to make sure that you sequence your treatments I wouldn't say properly, because I don't know if there's a right way or a wrong way, but just to maximize the number of options that you have.
Got it. Okay. We've talked about the best way to find a good clinical trial, but I'll say it again, clinicaltrials.gov, correct?
Yes, that's what I use.
Okay.
All the time.
Perfect. Excellent. Okay, for triple negative breast cancer patients, are there any tests for possible recurrence? We've touched on this a little bit, but are there any other tests that you would recommend to detect for recurrence? And is Xeloda appropriate post-surgery and chemo?
So I would say there's lots of emerging technology, and that's, where the ctDNA comes in, is that it's emerging technology. So it's not considered standard. So you could certainly discuss with your oncologist, ask them what they think about it, and if they think it'd be worthwhile for you. But it's emerging technology. In terms of capecitabine, is considered a standard adjuvant regimen for patients who've gotten neoadjuvant chemotherapy, and after surgery, if they had some residual disease in the specimen that's removed, that is considered standard for triple negative. And the good thing is capecitabine tends to be pretty well tolerated, and that your hair grows back, doesn't affect your blood counts. I always tell patients there are 3 side effects, which is diarrhea, mouth sores, and some hand-foot syndrome, red and swollen hands and feet. But those are actually not that common anymore, because we've been working with capecitabine for such a long time that I can't remember last time I saw mouth sores or diarrhea. And the hand-foot syndrome you have to manage, but usually there are lots of different strategies out there, including changing dose, changing schedule. I've used a nicotine patch on patients to try to reduce some of the side effects. It's pretty effective. So lots of different things. So
interesting.
It tends to be well tolerated compared to, say, the AC and the T, which are tough drugs.
Speaking of hand and foot syndrome, somebody asked in the chat, will the ice booties work to alleviate some of the hand and foot syndrome?
Only for Doxil, but not for, so for capecitabine, you take it continuously, right? So with capecitabine, you take pills twice a day, either 2 weeks on, 1 week off, or 1 week on, 1 week off. So it's not like you can have your hands and feet in cold in the cold all the time. The only thing we sometimes tell patients who are on capecitabine, if they've gone on a hike, or they're doing so where they will go out running, when they come back, they should put their feet in cold water, because sometimes they'll say their feet hurt after they've been running a few miles or something.
Got it. Okay.
I used a nicotine patch for the capecitabine, and as long as you're not sensitive to nicotine, because sometimes people can be a little sensitive, they feel a little hyper on it. It works nicely.
Interesting. Just over the counter nicotine patch?
7 milligram patch, yeah.
Wow. Okay. Okay. So can aspiration of lymphatic fluid be used as a tumor marker and determine disease progression?
So I'm not so clear aspiration of lymphatic fluid. I think about aspiration of lymphatic fluid when someone has a node dissection and they have a seroma under their arm and they take it out just to make people comfortable. I'm not aware of it being used for anything else.
Got it. Okay. Got it. One person asks, can you take the natural supplement Stone TM instead of Fosamax? Does that ring a bell?
No, I'm not familiar with that. Yeah, I've never heard of that.
Okay. And then one other question, if I had a bilateral mastectomy, does that impact triple negative breast cancer recurrence?
So I'm assuming that maybe one side may be prophylactic. So not real. I mean, most triple negative breast cancers, we tend to get distant recurrence. You might have a mastectomy for triple negative breast cancer in a couple of different situations. One, of course, the biggest one is that, the size of tumor, and you're, looking to get what we call negative margins. When you look under the microscope, you see only healthy tissue on the cut surface. Sometimes people do, mastectomies, they do for lots of different reasons, not only disease related. Maybe makes themselves even, but it doesn't affect recurrence per se.
Okay.
Unless it's local recurrence because you had a big tumor you couldn't cut out with just a lumpectomy.
Got it. Okay. Can you talk about a little bit about specific research that you're working on?
Yes, so I'm working on a few things. So let's see, I guess my biggest project is we've done a lot of work really looking to pull out the infrastructure the tumors need to spread. And we've done a lot of research, coupled with research that's done elsewhere, which we identified copper as a very important component of many of the different steps that tumors hijack to spread. And so we completed a pilot trial recently, and moved on to the next phase. So we're been working very, very hard to launch a randomized phase 2 study in about 186 patients of in women who have triple negative breast cancer. They get neoadjuvant therapy and they still have significant residual disease. You know, they would normally go on capecitabine, which they would do, but half of them will get TM and which is our copper depletion drug, and half of them won't. And so it's, you know, we don't have a pharma sponsor for this. So, you know, there's been a lot of work, organization from, I don't even know how many people to get this project moving forward, but that looks like it's moving forward. And if we're successful, basically what that means is that we've been able to take a low cost, well-tolerated drug, move it forward to prevent metastasis. So we're really hoping that we're right on this. So that is exciting for us. And plus the fact that, what we built into our trial, because we really want to know why something works, why something doesn't work, because we don't want to overtreat or undertreat people. And so we built a lot of science into that trial that the BCRF is supporting. So that's sort of slow, as I call it, a labor of love, right? We're moving it forward. I always tease my colleagues and say, I want this to be done by the time I'm ready to retire. But, I'm not getting any younger, so I really need to get it done. So that's exciting. The other thing that I'm working on up in Connecticut specifically is that we're working for a new pill for hormone receptor positive metastatic breast cancer. The drug doesn't have a name yet. It's called ARV-471, but it's it's a very well tolerated and appears to be effective drug. And one of the things I like about this trial is because it's sort of first of all, it's early, so that means that the company who sponsors it is really their eligibility criteria for the trial is really wide open, which is great. But it's also great because it has activity already and it's well tolerated. So I feel like it's a win-win situation. So that's pretty exciting because I think this drug will probably go all the way and get FDA approved. So it's exciting to be involved in something like that and to have patients have access to things early because it just makes them live better and live longer. So that's exciting. And then it's really great to be a part of MSK because they just have so much going on there from a research perspective. And there's so many, smart, passionate investigators there who are running all these different trials. They have a couple of very new targets, which I'm very excited to see if they pan out. One is a drug targeting something called a Notch inhibitor. And so we do a lot of sequencing. So we see a lot of our tumors have these Notch mutations, but there were no drugs out there for it. So I'm very excited to see that trial up and running. My colleague Tiffany Traina at MSK is running it. I feel like we're sort of on the verge. We're on the verge of understanding metastasis. We're on the verge of stratifying risk, who needs more or less treatment, and we're on the verge of really having a cocktail of targeted therapies for our patients. So,
excellent, good. A few more specific questions. Where could I find the list of various chemotherapy approved for triple negative breast cancer? This is specific to metastatic breast cancer to the bone. The person who's asking this has that.
Yeah, so there's really, as far as I'm aware, there's only one drug which really only says that it's approved for triple negative breast cancer, generally, and that's Trodelvy or sacituzumab govitecan. Atezolizumab is approved in triple negative PD-L1 positive metastatic breast cancer, but there's a whole list of other drugs which are active in triple negative breast cancer. It's just when those drugs went through the approval process, we didn't really know that there was such a thing as triple negative breast cancer per se, so they didn't it wasn't a targeted indication like that. But probably the best place to go, I don't know if there are two places you can try. One is cancer.net, which is the ASCO website. ASCO is American Society of Clinical Oncology, because they have a very good patient portal. The other thing that I'm not sure that you can access, but you can try, is NCCN, which is a website that basically will have approved drugs in breast cancer. And actually your insurers use it. So I don't think you need any kind of, I don't think you have to like set up a password or anything like that. I think, and actually they may even have, I think they do have patient related stuff on there too. So you could probably see the same things that we see. They're basically algorithms for treatment, and they include approved drugs, recommended drugs, all those kinds of things.
Okay. Excellent. Can triple negative diagnosis change years later to hormone positive recurrence? Can triple negative morph to hormone positive? If so, is it rare that happens?
It's not that rare. So I did mention before that breast cancer is like a bunch of grapes, and all the grapes have different characteristics. So some of them can be hormone receptor positive, some can be triple negative, some can be HER2 positive. So it's just a question of which sort of grape wants to spread to another site. So there was, this was actually looked at by a group, I'm going to say, it might have been Indiana, where they basically looked at a cohort of patients in order to sort of understand if you started out at one molecular subtype, so say triple negative breast cancer, what was the probability that you would switch your subtype? And it actually is anywhere, it can be 20% of the time, so it's not that rare.
Got it.
But I think the important thing is that you always have to keep your mind open, that, these tumors, like how they shapeshift, right? So you always have to, especially with HER2, you add in HER2 directed therapy, pull it out, so there's a lot of shapeshifting of the tumor that goes on.
Got it. All right, so I have one final question, unless anybody else has anything else that they want to put in the chat. I have one final question for Dr. Vahdat. Anybody have anything? Oh, okay, here's one. What about alcohol after triple negative treatment, drinking?
Yeah, so I would say, I usually tell my patients to follow ASCO guidelines, which you shouldn't have more than 5 drinks per week.
Fair enough.
So, moderation, right? People need to live.
Yeah. All right. What do you think about medication for LCIS following a triple negative diagnosis?
So, LCIS is is lobular carcinoma in situ. It is distantly related, you might think, in some ways to DCIS, except that LCIS is, if you want to think about it, more benign, so you don't really have to do anything about it. But it is a marker for progression to invasive breast cancer. So you could say it's about 10%. And so lots of times, depending on how much LCIS somebody has, we will usually recommend what we term chemo prevention. So no surgery, no radiation, nothing like that for LCIS. But for chemo prevention, which is somewhat of a misnomer because it's, what we recommend, neither chemo nor prevents breast cancer, reduces risk. And those are drugs we use like tamoxifen, both standard dose and low dose. We can talk about the aromatase inhibitors. So those are the kinds of things, or what we call lifestyle modifications. So things we know that can reduce development of invasive breast cancer, things like, once again, skinniness, right, is good. So BMI less than 25, exercise, low fat diet, no cigarettes, all those things.
Got it. Okay, so I have one more question in the chat. I had triple negative breast cancer in stage 2 in 2018, had chemo, surgery, and radiation. Sentinel nodes and lymph nodes were clean. What are the chances of recurrence? That's probably difficult to answer.
Yeah, I think without looking at everything. And, the other thing to sort of look about in your path report for triple negative, and you'll see it sometimes, is that if they say that they see a lymphocytic infiltrate, that means that there are TILs tumor infiltrating, and that's a better prognosis. So, looking for something good to like, sort of glom onto, so whenever I see TILs, I'm happy, and, because that means that basically if you have TILs, usually the triple negative is not that bad. It's more like a luminal breast cancer or ER positive breast cancer. So.
Got it. And you said that you prescribe Fosamax for your postmenopausal patients.
I do.
Okay.
For 3 years. Yep.
Got it. Okay. Okay. So we're almost out of time, but just one last question for you. So we are all of us who participate in this group are in various stages of treatment or post-treatment. We've all got our own medical teams. What is the one kind of piece of advice you would give somebody, or what's the one thing that you wish that your patients knew walking through the door and, and dealing with the diagnosis or dealing with a doctor or a medical oncologist on a cancer diagnosis?
Well, I mean, I think, when you talk about breast cancer, no matter what its molecular subtype, is that there are always options, and that, I always feel that it's great when patients, if they're capable, like, because not everybody wants to deal with this, but I feel like being proactive in your care and your health in general just makes everything easier. Because I think one of the things that has always struck me, about cancer is that I think so many people feel out of control, right? You're like, oh my gosh, I've done everything right. And how do I have cancer? So you feel out of control. So I think it's important to try to figure out ways to sort of get control back, right? In sort of an uncontrollable situation. And the ways to do that are being proactive, always making sure you're well informed as best as you can, if that's something that you want to do, because some people don't want to do that. But if that's a good coping strategy, that's what I would recommend. And to do things which are healthful, like, walk, exercise, good diet. I think one of the things that's come out in this discussion today is that fat is, like with everything, fat is bad, right? And so really focus on trying to get to a BMI of 25, some exercise. You don't have to go crazy, but you have to think about being healthful.
Wonderful. Well, thank you so much for participating with us tonight. This was a really excellent program, and we appreciate you taking the time to answer all of our questions. And I've learned a ton, and I think that everybody else did too. So thank you very much for your time and for all of your insight. We're very grateful.
My pleasure, and good luck to everybody.
Thank you.
Bye-bye.
Take care, everybody. See you next month.